Hypertension is not just a high number. It is a compounding, systemic regulatory error that physically worsens the vascular system over time. Safely lowering this pressure requires manipulating specific variables within the body's internal circulatory logic. The core mathematical framework of the cardiovascular system is blood pressure equals cardiac output multiplied by total peripheral resistance. Cardiac output combines total fluid volume and the mechanical speed of the heart. Total peripheral resistance represents the physical narrowness of the vascular network. These 8 primary classes of antihypertensive drugs act as distinct mechanical levers, each designed to alter one specific variable within this equation. While all 8 classes effectively lower blood pressure, the clinical selection is dictated by a patient's secondary comorbidities and their specific tolerance for side effects. Mastering these therapies requires mapping each drug class to its exact physiological target and the patient's unique clinical profile. We begin with the first variable, total blood volume. Mathematically, reducing the amount of fluid in the system guarantees a lower pressure. Diuretics serve as the primary tool for this, forcing the elimination of excess sodium and water to drain volume from the vascular space. Thiazides, specifically hydrochlorothiazide and chlorothalidone, are the frontline choice for long-term blood pressure management. A typical starting dose for thiazides ranges from 12.5 to 25 milligrams, taken once daily. These are distinct from loop diuretics, such as furosemide. Loop diuretics are reserved for rapid fluid removal, primarily in patients experiencing severe edema. Reducing this volume physically unburdens the entire vascular network. Volume depletion provides the most direct method to decrease cardiac output, forming the bedrock of chronic pressure control. Shifting to the mechanical pump, we address cardiac mechanics and sympathetic neurological drive. Beta blockers, such as atenolol, metoprolol, and propranolol, work by blocking adrenaline at the cardiac beta receptors. Blocking this adrenaline reduces both the heart rate and the overall cardiac output. These are highly effective for patients with arrhythmias or those who are post-heart attack. A standard starting dose for metoprolol is 25 to 50 milligrams, administered twice daily. Clinicians must use extreme caution when prescribing beta blockers to patients with asthma. Moving further upstream into the brain, we find central alpha agonists, like clonidine and methyldopa. These drugs stimulate brain receptors to dampen the entire sympathetic nervous system globally. Methyldopa is the preferred choice for treating hypertension during pregnancy, while clonidine is typically reserved for cases of resistant hypertension. Dampening this sympathetic drive actively protects the heart from overworking and aligns neurological signaling with safe cardiovascular limits. We now move to the second half of the master equation, total peripheral resistance. Resistance is driven by smooth muscle contraction. When calcium ions enter these muscle cells, the arteries constrict and narrow. Calcium channel blockers like amlodipine and nifedipine prevent this entry, forcing the arterial smooth muscle to relax. These are particularly effective in elderly patients and individuals of African descent, with amlodipine often starting at 5 milligrams once daily. This vasodilation can cause peripheral edema or smelling, specifically in the ankles. A second class of dilators, the alpha blockers, includes doxosin and prazosin. These block alpha-1 receptors to decrease peripheral resistance, with doxosin typically starting at 1 milligram daily. Alpha blockers are often chosen for men with comorbid benign prostatic hyperplasia, as they also relax the smooth muscles in the bladder neck. Targeting peripheral resistance directly relieves the physical stricture of the vascular network, with selection based on side effect profiles and secondary benefits like prostate relief. The most complex driver of peripheral resistance is the renin-angiotensin-aldosterone, or RAA system. This chemical chain reaction defends high blood pressure. Renin converts to angiotensin 1, which is then converted into angiotensin 2. Angiotensin 2 is the ultimate target. It is a highly potent vasoconstrictor. Direct renin inhibitors, like aliskiren, block the very top of this chain to halt the cascade at its inception. Aliskiren must never be combined with ACE inhibitors or ARBs, particularly in patients with diabetes or kidney impairment. ACE inhibitors, such as enalapril and lisinopril, move the blockade to the middle of the chain, stopping the conversion of angiotensin 1 to angiotensin 2. These are highly effective for protecting the kidneys in diabetic patients. A common limiting side effect of ACE inhibitors is a persistent dry cough. Angiotensin II receptor blockers, or ARBs, such as losartan and valsartan, directly block angiotensin II from binding to the tissue. ARBs provide the same vasodilation and renal benefits as ACE inhibitors without causing the dry cough, making the RAA cascade a highly customizable pharmacological target. Viewing the complete pharmacological landscape, we can categorize all 8 drug classes under their respective variables in the master hemodynamic equation. This framework allows us to connect specific comorbidities, like diabetes, BPH, or asthma, to their ideal drug class. Effective hypertension management relies on precise biological engineering of fluid volume, cardiac output, and peripheral resistance. The ultimate drug choice is determined by more than just the blood pressure numbers. A diabetic patient requires an ACE inhibitor, a pregnant patient needs methyldopa, and an older patient may require a calcium channel blocker. Clinical pharmacotherapeutics is the rigorous practice of matching a drug's exact mechanism of action to the unique physiological architecture of the patient.